see me in a hotel and not sure how the internet connection is going to last. So this might be very short. We're going to do our best. Thought I'd start things off by maybe, can you hear me? Let's try that. Ricky, Jackson, thanks for joining me. Can y'all hear me? Hopefully everybody can hear me. Ah, good. All right, we're going to go with that. You can hear me, you can see me. We're going to stick with the basics, tribe. So we're going to start with a question that was asked on another platform, and we'll roll with the punches there. I'll answer this question, and then if anyone in the live chat has a question, send it on over into the live chat. Depending on where your screen is, might be on the left, might be on the right, who knows. Send me your questions. I know there's this thing called Super Chat. Don't know if that even works. I'm on my laptop in the hotel. We're going to see what happens. So one of the tribe members asked me if I ever, question was, hey, Sean, have you ever made a medication error? And this particular tribe member was very distraught over how the error had affected them. They couldn't get over it, or they were having a hard time getting over the fear of making another error, and wanted to know if I've ever made an error before. And the truth is, I've made several errors. The first medication error I made, I was probably in my second year as a nurse. I was working in the ICU, and I made a medication error. I programmed the IV infusion incorrectly, and that particular IV infusion was a narcotic, and I gave a larger dose than was ordered. We'll leave it at that. Now, granted, this was greater than a decade ago, but I'm still not going to give you the details. And wanted to know how I felt about it and what I did about it. Ultimately, I was scared out of my mind, and the best thing that you can do is be upfront and honest about it, and to communicate with everybody that you need to communicate with. Transparency is probably the most important part of making a medication error. It does get better. The fear will lessen, and you have to remember, no matter what, that you are not perfect. Nurses are not perfect. We are human beings, and we will make mistakes. It's just that simple. You are not superhuman. We already have a number of questions rolling in through the live feed here. John is asking, do female patients find it awkward to ask them to lift their left breast to take apical pulses for 1 minute? That's a very interesting question, John. I have never had a problem with that part of my assessment, ever. I must just emphasize that the best thing that you can do is to maintain your professionalism. There is no other way to address that. Some, younger patients may feel a bit uncomfortable. It's your job as a nurse, whether male or female, it's your job as a nurse to maintain professionalism. You have to make sure that you treat that part of your assessment the same way you would treat listening to the lungs, listening to your bowel sounds, or assessing skin, or doing a neurological exam. You need to approach all of those elements of your assessment the exact same. If you show some signs of discomfort or some other type of emotion during that part of the assessment where you have to lift up the patient's left breast, then they're going to feel the same way. So do yourself a favor, do your best to maintain professionalism and treat it as if you were, once again, doing the neuro exam or you were assessing, reflexes. It doesn't matter. You have to treat everything the same. Hope that answers your question. Stephanie is asking advice for a nursing personal statement. I do not know what you are asking there, Stephanie. Personal statement. Are you asking in regards to an application for nursing school, or for maybe for a grant, or for scholarships? Personal statement is exactly what it sounds like. It has to be a personal statement. It has to be something that is personal to you. Are you talking about you're gonna have to be a little bit more specific there, Stephanie. A personal statement is very vague. So I'll come back to your question if you can maybe define it just a little bit better. Ricky is asking, what is my relationship as an NP with pharmacists? My relationship with pharmacists is collaborative and active. I work in the ICU for, as most of you already know. We have a multidisciplinary team. We have multidisciplinary rounds. I communicate directly with our PharmD, our pharmacists -D. They have their doctorate in pharmacy, or they have a doctorate in, I guess pharmacy. I really asked that question. So I communicate directly with my pharmacists. I have to. When it comes to the management of multiple ICU patients, the very least of which has to do with medicine reconciliation, all the way down to antibiotic treatment, antibiotic therapies, escalation and de-escalation of antibiotics, depending on, what illness you're treating. So my relationship with my pharmacist is awesome, but maybe that's not the case with everybody else. Jackson is asking, as an ICU nurse, do you think that as a high school student, they should start EMT training, or wait till you graduate, then get EMT and med license all at once? I think the sooner the better. I don't think there's any disadvantage to a high school student starting to take their EMTB course. If that's what you truly want. I don't think there's an advantage or a disadvantage. I just think it's additional training. It will help you with perspective, and of course will help you with the basic assessment skills. Also, you'll be able to, you'll have a leg up on EKG assessments. So there's absolutely no drawback to that, other than the fact that you have other schooling you have to worry about. Jackson, also, is it patient restraint something that could turn into legal trouble for healthcare? Oh, so Jackson, you're talking about your other question. So hope I answered that. Steezy, interesting name. Steezy's asking, any recommendations for new grad RNs about to start their first job? I have several videos that I already have on my YouTube channel. When this chat is over, you should go check them out. The best recommendation I can give for when you're a brand new nurse starting out in your first job is to get a notebook and to utilize the 2-to-1 ratio. You have 2 ears and 1 mouth. You should listen twice as much as you speak, because you know nothing. Okay. Not really sure what chronically Zoe is asking me there. So Kathy's want to know, how was my work schedule when I went to NP school? I worked full-time until the last year. My program was set up, it was structured uniquely. I only had a class once or twice a week outside of my clinical experiences. So I was able to work full time up until the last year or so. And then I went part time slash per diem. Um, my wife took one for the team and helped support the household. And I also, took out loans and grants, knowing ahead of time that I was not going to be able to work full time. So every NP student approaches that a little bit differently. Christian, hope I pronounced that right. Christian's asking, how do you handle unexpected violent outbursts from patients who suffer from dementia? Patience, patience, patience. It you can easily get wrapped up in the um, anger of having to deal with repetitive, unsafe behavior. But you have to continue to remind yourself that this patient has a illness that they have no control over. You're speaking of dementia. So the other thing that I always tried to remind myself was, if this was my family member, how would I want them treated? If it was my grandmother or my grandfather, if it's my mom or my dad and they have dementia, how am I going to feel if their nurse is treating them a certain way? So you want to make sure that you always remember that that patient is somebody's family, and you want to treat them as such, no matter how hard that question. Now, how hard it is to care for those patients who have dementia. Ricky, you're welcome. Answering your question. Miss Kelly Renee, nice name. 3 weeks into a nursing program and anxious, learn to start IVs. How long does it take to get comfortable with inserting IVs, and what advice do you have? It's going to take you a long time. When I was a bedside nurse, it took me several years, and I actually had formal training. So back in the day, when I was a bedside nurse, I graduated from a diploma program. And in that diploma program, you were required to start 3 IVs on patients. You had to start 3 IVs, successful IVs, or you didn't graduate from school. We were not allowed to practice on ourselves, at least legally. And when we were in our last year of our clinicals, last semester or two, you had to start 3 IVs. And then when I went and started my first job in the ICU, during my ICU orientation, during that first job, you actually spend a day or two with the same day procedure department, like the PACU, or going into the cath lab kind of patients that need an IV for conscious sedation, going to the GI lab. You spent the entire day for 12 hours just starting IVs all day. So it was trial by fire to learn how to do peripheral IVs. It takes time. It takes practice. There is no better educator than experience. Kristen's asking, how was your ICU's relationship with other departments, with the PACU and the step down? My ICUs over the years, their relationships have varied. In the smaller hospitals, they seem to be at least a little bit more collegiate, a little bit more collaborative, a little bit more laid back. In the larger hospitals, it's a little bit more disconnected. Although, you always find those relationships with ICU and the ER and the PACU, the ER and the PACU. And if you work in a surgical ICU, you're getting surgery patients all the time. You do create a good rapport with those neighboring departments, but as you have already probably hinted, the relationship can be stressed. So you have to do your best to remember that not everybody knows what you know, not everybody's experienced what you've experienced, and that life is very different outside of your unit's walls. So yeah, personalities have clashed. I will admit that. Jackson. Sorry, guys, reading some of the comments here. Hey, Nurse Bass, thanks for dropping in for a hot minute there. Aaron, who's a new nurse 2 months ago. What was it like when you were on your own and have no preceptor? I'm confident I can manage patients' care, but I'm curious to know how it went for me personally. I was scared out of my mind when I first started as a brand new nurse coming off of orientation. There's always that underlying fear of harming a patient or making a mistake, a medication error, or screwing something up, or not being able to manage the load. It's always going to be there. The comfort level comes with time and experience. I say it over and over and over again, that experience trumps everything. So as time goes on, you will get better at everything you're doing. The initial fear is there for everybody. There is not a person, not a nurse out there that didn't have the same fears that I had and the same fears that you probably have or will have. Welcome to the club. John's asking, is it bad to use Lysol on my scrubs when I get home? Haven't done it, but scared of bringing home pathogens. Yeah, it's probably bad to put Lysol on your scrubs. I can't say that I've ever heard anyone ever do that. If you truly are worried about bringing home the bugs, then change at work. Those who work in certain areas, they wear, their regular street clothes, or they wear regular clothes to work, and then they change at work. They have a dedicated pair of shoes that never leave the hospital. I mean, going on the assumption you have a locker and someplace to lock things up, but you can, wear the scrub, bring the scrubs with you, change at work, when you're there, and on your way home, when you leave for your shift, you can also change there. Yeah, that's all I'm going to say about that one. Mammy, Marty. Wow. Sorry, guys. I gotta drop some eyes or wear my glasses next time. So, do I see many GSW patients? How do you provide good care for these patients? I see GSW patients all the time. I work in a trauma unit. I work in the ICU. So I've seen GSWs my entire nursing career, and I treat them the same way I treat all my other patients. You have to separate yourself from the reason that put them in the ICU. It is not, you are not judge and jury. You do not get to decide if someone is guilty or innocent. You do not get to decide if someone is good or bad. You get to decide if you're going to be their nurse and take care of them. Sorry, John, I'm not weighing in on either one for the Super Bowl because I'll be working, so it won't matter. And if I'm not working, I'll be driving. I'll be commuting home. So, soon to be a new aide, currently waiting to get into the LPN program. Excited and motivated. My question is, how do you deal with unmotivated burnout nurses or aides when you are so excited? My best answer is to shrug them off, scrape them off, and concentrate on those who are excited with you, because those people that you're talking about are going to be present no matter where you are in your career. There are people who are as excited as you are to become a nurse, as well as when you graduate and you start doing the job. But there will also be nurses out there that just want to see the world burn. There are some burnt out harpies out there. It's your job to make sure that you ignore them or do your best to change their mind. Having a hard time scrolling through all the comments here, guys. This is awesome. Thank you so much for hanging out and posting your questions. I'm trying to keep up. Stephanie asking me what made me realize I wanted to do nursing. I shared this a while back. It might be in one of my YouTube videos, not sure, but it had to do with having a personal experience as a patient. That's a story and a video in itself. The short version is I discovered very quickly how impactful nurses can be to patients. I was in the hospital for 2 days, and this was, 15, 18, 19 years ago. I was in the hospital for 2 days. I had 2 nurses take care of me on day 1, 2 different nurses on day 1 versus day 2, and they were 2 completely different days that I experienced. Day 1 was quite miserable, and day 2, I felt like I wasn't even in the hospital, even though I was suffering and in pain. And that sealed the deal for me. Not to mention, it was the first time I ever met a male nurse, and I got to chat with the male nurse, and he educated me on how wrong I was about what nurses are and what they do. Still remember his name, John. First semester student RN. All right, John, thanks. Aaron says he's having a hard time, he or she, sorry, having a problem with time management. It gets better, but in the morning it's usually crazy. Sometimes I have no time to read doctor's notes. Is this a normal feeling? Abso-freaking-lutely is it normal. Time management also comes with time and experience. The other thing that I would recommend is to buddy up with those who have figured it out. Find some of your fellow coworkers, colleagues, as well as senior nursing staff who have figured out how to manage their time better than you. You're still brand new at this. You're still trying to figure out your path. You're still trying to figure out your pace. Everybody does it a little bit differently. I'm not saying you have to repeat and carbon copy and mimic everything that somebody does, but maybe you can take pieces of what coworker A does and what coworker B does, and a little bit of what your charge nurse does, and you can mold that into something that is efficient for you. It took me a great deal of time to get my time management skills sharpened, and every time, every day is a different day, and some days you're in front of the 8 ball, sometimes you're behind the 8 ball, and there are some days when the 8 ball just runs you over. So, welcome to nursing. Jackson wants to know what a GSW patient is. That's a gunshot wound. So, someone who suffered a wound from a gunshot, which could be any kind of gunshot. So, use your imagination there. Chronically Zoe says, I'm hoping to become a nurse. Do you have any advice for a hopefully new nurse? That is a horribly generalized question. If I had to give you any advice, it would be make sure you go into this profession for the right reasons. If you're going into this profession to make money, to get the thanks, to have people appreciate you, you might want to rethink what you're doing. Nursing is mostly a thankless job and a thankless profession. You truly have to love this stuff in order to live it. And if you don't believe me, just ask anybody from the tribe or ask any nurse that you know. It looks like someone already answered the GSW question there, so thank you, tribe. Let's see here. Data 2 graduate RNs this year, nurses like you, Nurse Bash, Ash Sharma. Oh, thank you. Thanks, Steve. Appreciate that. Coco, longtime follower, you're awesome. Oh, thank you very much. Jackson says, what's your opinion on nurses in whites and caps? My great-grandmother was an RN from 58, and she always wore her dress and cap. I mean, I don't have an opinion. I mean, that's just the way it was back then. Showing my age, but my nursing school, we wore all white. I looked like a walking Q-tip. Yes, we wore all white. I graduated in all white uniform. There were specifics to, there were requirements for the white uniform. You had to wear white shoes and white socks, and you had to wear white undergarments. Oh yeah, yeah. I'm one of those nurses, so I'm not really sure what you'd like me to say. I don't know if it's unsanitary, not. It's not functional these days. I don't think there's a nurse out there that would be able to do their job these days. These kind of now greatly evolved. Um, even from 1989, as you have listed here, Jackson, the nurse has changed immensely. I don't think we'd be able to do the job that we do in a. Sure, you could, but how many people would prefer it? I guess, and is people like me, men, who probably aren't going to wear the dress. John wants to know, how do you verify NG2 X-rays? Yes, that is that is an X-ray. Auscultating over the abdomen at the juncture, or the the xiphoid process. That is not most accurate form. You can have a general idea that you are in the stomach, but the evidence has proven, and experience will prove, that you'll listen to it over the xiphoid process, and then when you get an X-ray, it would be in the lung, because it can be in the lung, and you actually hear it over the xiphoid process. So yes, X-rays is the most accurate, and it is the standard of care. So I'm trying to scroll here. Someone's asking a patient-specific question. Wanted a code status change, wanted chest compressions, no defib or intubation, a limited code, or even a DNR. Yeah, this is a tough question, Aaron. We're talking about code status. Aaron's asking, a patient wanted to change their code status to chest compressions, no defib or intubation. My answer would be that we would have to have a better conversation with that particular patient, because chest compressions but no intubation or no defib is quite literally assault. There's absolutely no benefit to any of that. She wanted to be a DNR. How do you, as an NP, talk to a patient about that? The best thing that I can say to you, and what I say to my patients, is that the heart and the lungs work together as a team, and I can't treat one without the other. You cannot do one without the other. One will fail eventually, either immediately or with a good bit of time, especially if you want to do chest compressions but you don't want to do intubation. Chest compressions without intubation is assault, because as everybody knows who knows their BLS, ABC, airway is always first. Doesn't matter how hard you pound on the chest or how many fancy medications you give, if you can't oxygenate the body, game over. And vice versa, if someone is okay with intubation but not chest compressions, you still need to educate your patient, because there's a lot of things that will happen with that particular limited code. It is perfectly within their rights. If they are adamant and that's what they want, then that's what they get. But you have to, me as a provider, and you as the bedside nurse, need to educate them on the ramifications of that decision. And it's actually within your scope of practice as a nurse to give that level of education. You can give them the specifics on pathophysiology, and you can give them your experiences thus far in your career on what you've seen. You do not want to tell them that they're right or wrong. You simply tell them what they will experience. Leanne is agreeing with me that it's a thankless profession. Yes, if you're wearing all white, to wear white undergarments, yes. John says, are smartwatches okay for the nursing profession? They're okay. I believe ZDoggMD actually had a video over the past several months, maybe in the past year, that talked about using it as an approved medical device. I'm not gonna dive into that one because there's so many things we could talk about. I would look up ZDoggMD's video on that particular topic. He covered it very well. Kristen says, "Thank you for being a positive example of the nursing community. Any tips?" Well, you're welcome. Thank you. Any tips for new preceptors for precepting new grads in a busy CVICU? I can think of 3 things immediately if you're a brand new preceptor. The first is you need to remember where you came from. If you can remember what it was like to be in that new nurse's shoes, you will avoid a lot of heartache and you will avoid a lot of stress for you and your new orientee. So your first thing is to never forget where you came from. Never forget what it felt like to be the new person. The second thing you got to remember is that everybody learns differently. Some take stern direction. Others need the soft touch, and others are okay with the sarcasm. Everybody is a little bit different. Personalities will vary, and learning abilities will vary. So you have to flat out sometimes ask your orientee what it is. How do they absorb? Is the see one, do one, teach one mentality? While it is tried and true, some people don't do well with it, or some people need to see a couple before they do a couple, and then before they actually perform it. So, but I also would encourage them to, teach back whatever they can. I said 3 things, and the third thing is you have to remember that you are not always right, and you are not the only way. This is usually the hardest pill for preceptors to swallow, is that you want to be the answer person and the end-all be-all for your orientee. But the reality is that maybe you don't have the best answer. Maybe you don't have the best way to do something. Maybe someone else, some other colleague, some other coworker, some other orientee has a better way of doing something. You need to keep an open mind. It's your job to prepare that new nurse. It's not your job to always be the one with the answers. Hope that helps. John's asking, what is my experiences with travel nurses, minimum experience before starting travel? I did travel nursing during the first 2 or 3 years of my career, and I can say without a doubt, you should have a minimum of 1 year, preferably 2 years of experience before you decide to go travel nursing. Travel companies out there will tell you only have to have 6 months. Some will even tell you 3 months, depending on facility requirements. But I'm encouraging and imploring you to get at least a year, if not 2 years, because travel nursing is tough. You hit the ground running, and you have to figure it all out on your own. They give you limited resources to perform the job that everyone else is performing in that facility. So you have to be resourceful. Who else we got here? Kristen's talking about the code status question. Thank you. Dre is saying I have an associate's degree. They have an associate's degree in science, 3 months from finishing LPN. Should I go to the LPN ADN program, LPN to BSN program, since I already have a degree in science? As an ADN grad, I will tell you that you do what is best for you in your life at this moment. If you have the means, mode, and finances, I would encourage you to go to your BSN. Go to LPN BSN, because BSN is becoming the standard, the minimum requirement and standard. It is not yet across the board. The state of New York has started it, if you don't already know that. So I would encourage you to go straight to your BSN if you can. You will have much more. Your job opportunities will be exponential compared to your job opportunities as an ADN. Kathy wants to know, how do I handle rude doctors? I handle rude doctors the same way I handle rude patients. What you allow will continue. You decide how people treat you by what you accept. I'm not saying you have to be confrontational. I'm not saying you have to be argumentative. I am saying that you deserve their respect. You deserve their respect by giving respect and accepting respect. If someone is being disrespectful or rude or obnoxious, the first thing is to not have it happen out in the middle of patient care areas, especially at the bedside. You need to step away, excuse yourself, and you need to have a frank and meaningful conversation with whomever that doctor is. Usually want to bring in reinforcements if it's that dicey of a relationship. And someone's being rude and someone is raising their voice and they're just carrying on like a child, the the recommendation I had from a seasoned nurse back when I was a brand new nurse in my first or second year was to start off with the whisper test. Is that the louder that they talked, the softer your voice gets, and eventually it drives them insane and they stop yelling at you. I promise you, it works every time. You just have to be patient and continue with the whispering voice. Stephen, how are you? Stephen says, hey, Sean. Chris is checking in on my first live stream, second semester student. Rough first test today. Don't worry, Chris. There's probably going to be a lot more rough tests. You got to figure out how to bounce back. If you don't know what the bounce back is, you should ask one of my other tribe members or look up my videos. The bounce back is something you're going to have to learn. And remember, you're choosing a profession that is supposed to be difficult to get into and to pass. Because if it was easy, everybody would be doing it. Steven says he just got home passing his head-to-toe checkoff. Congrats. Aaron, I say a lot, guys. Why am I saying Aaron says, any tricks for inserting a Foley with a male who has an enlarged prostate? Had a patient the other day who had that and struggling. Here I am saying again. The recommendation is if you can't insert it by standard means and you've tried different sizes of Foley catheters, including the what they call the Coude catheter. If none of those if you're not successful, you only should try once or twice or have your colleagues try once or twice. Quite honestly, if you already know that somebody has an enlarged prostate, a lot of times you just have to consult urology. Depending on which facility you're in and the resources you have, you may have to call in that nurse that has the experience and who can hopefully save the day. Kristen, Texas is saying, is it easier for psych nurses to get hired with an ADN? I don't know the answer to this one, Chris. First of all, I'm not a psych nurse and I have zero experience with psych nursing. And does it get easier? Is it easier for them to get hired with an ADN? I have no idea what the job market is like for psych nurses. I don't know if they require a BSN or an ADN. So I wish I could give you some more insight on that one. Sorry, Chris. Going up on 40 minutes on this live stream. I think we're going to call it a night, tribe, unless someone has some last minute questions. Probably going to wrap things up. Going to try and do more of these YouTube lives if I can. But my schedule, as everybody already knows, is a bit challenging as it gets. So I'll do my best. A couple more questions are rolling in at the threat of ending the stream. Aaron wants to know amiodarone for AFib, question mark. You're going to have to elaborate just a little bit more, Aaron, because yes, amiodarone is used for AFib, but it is not the only drug and sometimes is the wrong drug. So you're probably going to have to be a little bit more specific. Chronically Zoe says they went from sobbing so hard I couldn't breathe to being normal, bounce back. Yeah, you're absolutely right. And I can't say that I was sobbing, but the level of fear and self-wallowing I had, yep, I felt that. So I know how you feel. Elise says, hello, I know you have talked about something along the lines of an emotional bank. Was wondering what your thoughts are on management of this when one has depression. Sorry, Elise, there's no way for me to comment on this one because I have no experience with that. I'm actually probably the least qualified person to answer that question genuinely. So my best suggestion is to reach out to those who can help you with that. I am definitely not the person to ask. Ending it on a good note, I want to thank everybody that joined me for the live chat here. We had a great turnout for, little to no notice. Hopefully we'll do this again soon. I will do my best to schedule this as far ahead as I can. If you have any suggestions, any topics, any questions, be sure to send them my way. Links are always in the bottom at the end of every one of my videos. Also on the About section of my YouTube channel. If you've made it this far, I hope you've subscribed. I hope you share this with your nurse tribe, with all of your nurse crew. And how do I end every single video? Make sure you check your own pulse first.